Hi, and welcome to the last set of screencasts for muscles and structures related to the axial body. This is going to be a bit of a review, or kind of the same as your study guide. So I will be going through the trigger points of all the muscles that you'll need to know. There is one extra one on here as compared to your study guide. I will be putting it on a new study guide in the future. So, if you remember correctly, when we talked about trigger points in class, we talked about how they, they had some key aspects to them. So they were nodules in the muscle, and that with compression there could be all kinds of things happen: referred pain, sweating, heavy breathing, that kind of stuff. And ultimately, one of the key things for trigger points is, of course, referral patterns. So it is something that is one of those key things when we look at it, and that's sort of what all these slides are going to be on. First, before I get started on them, I just want to represent or talk about what's represented here in the slide when we look at these trigger points. Ultimately, every slide for every muscle has a picture on it that shows the referral patterns, and what I want you to note is that in some cases there are more than one, or one X, that represents the common spot where the trigger point is found, and then the referral pattern from this. So we see here with temporalis, there are 4 key parts where we might find a trigger point, and you can see the referral patterns for each one depending on where you find them. So with temporalis then, we can find that we have headaches due to an active trigger point as being a common representation and described as pain widely throughout the temple. If you remember correctly, an active trigger point is a trigger point that is causing signs and symptoms without it being touched or used. It's just actively causing a problem. So as pain widely throughout the temple, along the brow, behind the eye, and in any or all of the upper teeth, ipsilaterally, so on the same side. So if we look at trigger point 1, which we find here anteriorly, the pain is forward along the supraorbital ridge and downward to the upper incisor, so in this area here and down here. Trigger point 2 and 3 are upward and finger-like projections to the mid-temple area and downward to the intermediate maxillary teeth on the same side. So heading up in this region, and then down here are the intermediate maxillary teeth here. And then trigger point 4 is backwards and upwards, heading out here into the back part, the occipital area of the skull. If we get deep fibers in here, occasionally you will find referral to the maxilla, the upper bone, and the TMJ joint itself. The next muscle is another muscle of mastication, the lateral pterygoid, remembering its placement and part of it attaching to the disc of the joint of the TMJ joint. This results in a couple of areas of trigger points that we see here and here, the common areas. We find pain deep into the TMJ and into the region of the maxillary sinus. Remember, there is a sinus above the upper teeth here, so represented sort of in the cheek area and the TMJ itself. They're strongly associated to functional disorders of the TMJ. There is no distinction between the 2 divisions of the muscle, remembering that there's 2 parts to it, but it doesn't really matter. They both refer the same. So quite often, someone may come to you with a trigger point, with a temporomandibular joint pain issue, and it's quite conceivable that chicken or the egg is the trigger points causing the TMJ, and possibly the TMJ condition causing also the trigger point that we find in lateral pterygoid. The next muscle is medial pterygoid, and remember, medial pterygoid is on the inside or the underside of the mandible that we see here. So this is sort of reaching up underneath the inside of the mandible to find the trigger point that we find here. It is shown here with the part of the mandible removed so that we can see through the bone. Pain is poorly circumscribed in regions related to the mouth, so that the patient may claim that there's pain and not really sure exactly where it is, but may say, I find pain in my tongue. Pharynx is the upper part of the throat, and a hard palate, the roof of the mouth. Possibly also below and behind the TMJ, and could be including deep in the ear, but not to the teeth. The next is one that I work on quite often, is masseter. It's that's one that's on the outside from the angle, remembering here, and the lateral structures of the mandible. We see that we have a number of different places that we can find trigger points on the superior aspect, on the inferior aspect, at the angle, and the deep structures of the muscle. So the superficial layer is basically to the lower jaw, molar teeth and related gums to the maxilla. The anterior border and upper part is the upper molar teeth, adjacent gums, and maxilla, sometimes described as sinusitis. Below the midbelly that we see here is the lower molar teeth and the mandible itself. The inferior edge that we see here is an arc that extends across the temple and over the eyebrow to the lower jaw, sort of this circle, and the mandibular angle here to the this area in here. The deep layer that we see over here, the deep part, we find diffusely to the cheek and sometimes the TMJ. It is close to the zygomatic attachment, and when we find it there, it can be pain in the ear, and sometimes your patient may express that when you're pushing on this trigger point, they're hearing ringing in the ear increasing. That's what we mean by tinnitus. Our next muscle is the occipital frontalis. Remembering this muscle has muscle tissue anteriorly and at the temple, or sorry, at the forehead and the frontal area, and posteriorly at the occipital area with fascia between the two. The frontalis portion here that we see above the eye spreads upward and over the forehead on the same side, but it remains relatively local. Occipitalis that we see here in the back is a recognized source of headaches. Quite often when I work with patients who suffer from headaches in this area, I'll be working on this spot, and a lot of times it tends to get resolved. The pain refers laterally, diffusely over the back of the head and through the cranium, causing pain deep in the orbit. So what might surprise you, or may surprise your patient, is that they will express that for some strange reason when you push there, they actually feel pain behind the eye. Very, very common landmark for trigger points in occipitalis. Our next muscle is splenius capitis, and basically splenius capitis refers pain to the top of the head on the same side. One of the key things I want to remind you here is when we look in this cervical, upper cervical area, you're probably starting to realize there's a lot of muscle tissue in here. And one of the things that can help us in sort of discovering what muscle we may be palpating, aside from landmarking and those sorts of things, could be the type of trigger point. So you might be in a tissue in the neck, ask your patient, is there a referral pattern? They say, yes, I feel it to the top of my head. And that would suggest to you that there's issues in splenius capitis. Splenius cervicis, remember, does not go up to the head in terms of its attachments. The upper part here that we see, trigger point here in the upper part, is diffuse pain through the inside of the head, focusing severely behind the eye on the same side, and sometimes the scalp over the occiput. So this muscle as well can cause pain behind the eye. The lower part of the muscle down here can cause pain to the angle of the neck, so where trapezius and the neck kind of meet, and upward to the base of the neck. Our next muscles are the suboccipitals. They don't generally tend to differentiate from one muscle to the other on palpation, although we can see here rectus capitis, obliquus, and its other cohort here. We find the common trigger points are found here, and you can see that the pain referred inside the skull is difficult to localize, so the patient may not be able to completely localize it, but can be called something called an indurative headache. So this can be a headache causer as well. And the pain extends forward unilaterally, so on the same side, to the occiput, to the eye, and forehead, with lack of definable limits. Trigger points in this area the patient will not express as being behind the eye. Sternocleidomastoid mastoid, one of the more common ones. Remembering that there's two divisions to this muscle. There is a sternal division and there is a clavicular division. And they do divide and project differently with trigger points when we separate the two of them. Commonly, when we see X's like this, it means that trigger points can be found throughout the muscle. At the lower end of the sternal division, we find pain downward to the upper sternum and sometimes can cause a cough. At the mid-level, homolaterally, same side, arching across the cheek and into the maxilla, over the supraorbital ridge and deep within the orbit, the inner margin of the muscle, pain to the pharynx, to the back of the tongue. So it sort of gets represented here, coming here. So across the cheek into the maxilla, and then over the supraorbital ridge and deep within the orbit. I think I mentioned in one of the other slides that did have some trigger points. When we look at the diagram and we see the dark red as compared to the speckled red, the dark red represents the more intense pain the patient will feel, and the speckle represents a less intense pain that the patient may feel. The upper end can go along the occipital ridge behind the ear to the vertex of the head. If we go to the clavicular division here, at the mid-level is the frontal area, possibly to the other side. I affectionately call these the headlights. The upper part is deep into the ear and posterior auricular area in here, sometimes to the cheeks and the molars ipsilaterally. Upper trapezius, I'm only staying with upper. Lower will be talked about next semester. So upper has two trigger points, commonly here at the anterior part just above the clavicle, and in the posterior aspect here round by the superior just to the spine of the scapula. It's said to be the most common muscle for trigger points. It's also thought to be a cause for temporal headaches. So trigger point 1 that we see here, a couple of areas we can find it. They refer pain unilaterally upward along the posterolateral aspect of the neck to the mastoid process. It's a major source of tension headache. If the pain is extremely intense, it can enter into the side of the head, centering into the temple area here, sometimes to the back of the orbit, and may include the angle of the jaw. So that's if it's a very intense trigger point. But commonly it just comes up here to the mastoid process. Trigger point 2 that we see here more posteriorly is referred pain pattern lies slightly posterior to the cervical reference zone for trigger point 1, blending to behind the ear. Scalenes, again, don't differentiate their pattern, so either anterior, medial, or posterior will represent the same pattern generally. Any of the scalenes may refer pain anteriorly to the chest, laterally to the upper extremity, and posteriorly to the medial scapular border and adjacent interscapular area, which we see here. Anteriorly, persistent aching pain in two finger-like projections over the pectoral region down to the nipple area. Pain to the anterior shoulder is not described as deep and extends down the front and back. In other words, over the bicep and the tricep area. It skips the elbow and is found on the radial side of the forearm. We see here, and the index finger. Scalenus anterior commonly refers pain posteriorly to the back over the upper half of the vertebral border of the scapula and to the adjacent interscapular region, which we see here. Longissimus thoracis is the more common area. We find a couple of trigger points here. So if we look at L1 trigger point, pain in the back starting at the T10-11 area, pain in the back starting at the T10 and or 11 area extending down into the buttocks, which we see here, which is the intense area. Pain is often more significant at the bottom of the buttock. In the area of L1, it extends down to the top of the hip. Pain is often more significant at the top of the hip and the top of the buttock, which we see here. Our next muscle is iliocostalis. So we have iliocostalis trigger points are related to the parasternal muscles and can happen at any segmental level. So iliocostalis thoracis refers upward, while iliocostalis lumborum goes down. So thoracis is up, lumborum is down. At the low thoracic level, they can refer pain across the scapula, around the abdomen, and downward over the lumbosacral region. This is a fairly common trigger point I find when I'm working with patients. Sometimes around that abdominal area, they'll almost say it's almost into their groin when you're palpating here. And at the upper lumbar region, pain is referred strongly downward, concentrating on the mid buttock. And at the low thoracic level, pain refers low in the buttock. One thing I want you to note about this T6 thoracis area is you can get some anterior discomfort in the chest as well. Semispinalis capitis has 3 common trigger points. Trigger point 1 being the most superior, 3 being the less. Remember how I talked about when we were looking at splenius capitis with a lot of the muscle structures that we see here. If you can take the time to compare the structures in the neck and in their common areas, you can see how you can divide the various muscles that we find in the cervical area when palpating and finding referral patterns to help you determine what muscle you're likely on. So trigger point 1, pain and tenderness is upward to the suboccipital region and sometimes down the neck to the upper vertebral border of the scapula, which we see here. Trigger point 2 is found 2 to 4 centimeters below the occiput, and pain refers over the occiput and towards the vertex. And trigger point 3 is the referred pain travels forward like a band that half encircles the head and reaches its maximum intensity in the temple area and the forehead over the eye. It does not refer pain into the neck, the trigger point 3. Multifidi, going a little bit deeper here. Basically, the patient may talk about how the bone is aching. Refer pain primarily to the region around the spinous process of the vertebra adjacent to the TVP. Remembering this multifidi is in that laminar groove, so it's kind of keeping into the common area. Whereas if they're located around the L4, L5 area, they can also refer pain anteriorly to the abdomen. And all the way down deep at the S1 level, pain can be projected down towards the coccyx. Serratus posterior superior. Now we're heading relatively deeply into the layers of the back. So we're looking, a muscle that finds a very close attachment to the rib cage. Trigger points here frequently cause scapular and shoulder pain. The pain can be expressed as a deep ache under the upper portion of the scapula, the posterior border of the deltoid, and the long head of the triceps muscle. It often covers the entire triceps region, the medial epicondyle of the elbow, and occasionally includes the ulnar side of the forearm, hand, and all of the little finger. On occasion, you can get some discomfort here in the pectoral region. Our next muscle is serratus posterior inferior. Remembering it's down here, arising from the midpoint up into the lower ribs. We tend to find an aching discomfort over and around the muscle, extending across the back and over the ribs ipsilaterally on the same side. Intercostal muscles are basically pain over and around the trigger point itself. They don't generally tend to have a large referral pattern. They can refer a small distance along the adjacent intercostal space anteriorly and posteriorly. Rectus abdominis, tend to find the trigger points here at the top or down here by the pubic bone in the bottom. The upper rectus abdominis on either side can refer pain to the mid-back bilaterally. Periumbilical rectus abdominis can produce sensations of abdominal cramping or colic, meaning upset stomach. Lower rectus abdominis in the lower part may refer pain bilaterally to the sacroiliac and low back joints. They say here, this is just for information. I've never seen a lot of research on this, but Travell does talk about how trigger points in the lower abdominal, halfway between the umbilicus and the pubis, when resolved, can relieve dysmenorrhea, which means painful period. External obliques and lateral abdominals. The external obliques can produce a heartburn and may also produce deep epigastric pain, which we see here. In the lower lateral wall, we can find referred pain into the groin and testicle and may project fingers of pain into other parts of the abdomen that we see here. Now, Travell claims that there's a belch button that if you push back in here, you may cause the patient to belch. I don't know if that's true or not. I'm more concerned with these referral patterns that we see here. Quadratus lumborum, this is the guy you're going to know the most. You're going to be working in here a lot. You tend to find an awful lot of trigger points in here, especially with low back problems. Also, if unassociated to some degree discal issues. Very common to find trigger points in this muscle. You find them either deep or superficial. You can see superficial here, meaning out at the lateral edges of the muscle, or deep is getting in close to those transverse process attachments. Superficial, at the upper part of the muscle, it refers along the crest of the ilium and sometimes to the lower quadrant of the abdomen, and occasionally they can extend to the outer aspect of the groin. The lower part, the caudal part of the superficial trigger point, can refer pain to the greater trochanter and the outer aspect of the upper thigh. Very common referred pain patterns. Deep, we have a upper cephalad and a lower caudal. The cephalad refers pain strongly to the area of the sacroiliac joint bilaterally and may refer pain that extends across the upper sacral region. The caudal trigger point of the lower part can refer pain into the lower buttock. Get to know these guys because you're going to find them a lot in your patients. Thanks for listening. This ends the last set of slides for screencasting. Good luck on your study.